So this is a what the hell episode of the Thyroid Fixer podcast. I guess we can title it WTF as well, but we'll just keep on Apple's good side and title it WTH. What the hell? What the hell is with functional practitioners being concerned about your TSH being suppressed? Now, how many times have I been on here bitching about functional practitioners using the term functional? That includes integrative, that includes alternative, whatever name you want to use in your title, although functional is kind of the up and coming name since we have the functional medicine department at Cleveland Clinic, the functional medicine department at Mayo Clinic, even though those clinics are far from functional 99% of the time, because I get patients from the functional medicine department at Cleveland Clinic. And they're with docs that shouldn't even have the term functional. I don't even know if they went through IFM or FMU to be trained. Don't know, but they shouldn't be using the term functional. Today, I want to focus on all of these functional practitioners and one point in particular, suppressed TSH. We have gone over this over and over again. I have multiple podcasts about this if you want to dive more into it. But in a nutshell, here today, I want you to know suppressed TSH is not a problem unless your free T3 and free T4 numbers are severely elevated and you actually are in a hyper state. Now, let me sidestep. Free T3 and free T4 elevated, provided that you did not take your medication within 24 hours of getting those labs. Because I've seen a couple of you post your labs and you look hyper and your doctors think you're hyper. And then I ask you if you took medication, let's say the morning that these labs were taken, and you say yes. Well, no wonder both of those lab values are elevated. Does that mean that you're not hyper? No, you still could be. But chances are pretty slim that it's the medication being picked up in the lab showing that you're elevated, but you're really not. It was just that moment in time. Because remember, if you are on a T3 containing medication, that can be NDT, that can be leothyronine or cytomel added to your T4. That could be supplements. I always talk about the ancestral supplement beef thyroid. Love it, love it. It's a glandular, but it contains T3. So if you take that and then you go get your labs done, you're going to have elevated T3. If you take that on a regular basis, your TSH will become suppressed. Now, TSH can become suppressed on T4. Many of you are on T4 only, and although it's probably not doing anything to reduce your symptoms, it can be reducing your TSH value. It can be pushing it to below a 1, essentially, when anything goes below, when that lab goes below a 1, not anything. When that particular TSH lab goes below a 1, you are considered suppressed. So now you are 0.7, you're 0.5, you're 0.05, 0.0005, because you're on T3, and that will naturally suppress your TSH. Also, if you are a thyroid cancer survivor, we want to keep that TSH suppressed. We want to, because we do not want to risk tissue growth. And when that TSH starts to come up, even between a 1 and a 2, a functionally optimal 1 to 2, then there can be issues with the cancer recurring in the thyroid gland. We want, even if you had your thyroid removed, we don't want any tissue regrowth in that area. So we keep the TSH suppressed so your pituitary is not sending out signals to stimulate tissue regrowth. We want that suppressed. We want it suppressed. Now, do we always want your TSH suppressed if you have your thyroid still? And let's say you just have Hashimoto's and you're walking around doing your day-to-day thing and you just want to feel good. No, it's not a goal. The goal is to get your TSH below a 2. But if TSH suppression happens, we certainly do not start changing and dropping your medication because of that lab value. And we have to go back to, and this is part of the what the hell, because functional practitioners know basic biology, and they know that TSH is a pituitary hormone. This is not me talking to the general lay person. I am talking to functional practitioners out there that I know in school you were taught that the optimal TSH is between a 1 and 2, and that is stuck in your head. But there is nothing wrong with dropping someone's TSH or someone's TSH dropping. It's not like you're trying to do it. It's just happening because you have a person on some kind of T3 therapy, or they've been on T4 therapy for a long, long time. And that TSH goes down. It gets suppressed. Look away from it. Look away from the TSH. In fact, don't even test it. If it's going to tempt you to drop someone's medication because you're stuck in some old school learning that TSH has to be between a 1 and a 2. Many people thrive when their TSH is below a 1, and many people don't thrive or experience hypo symptoms if they're at a 1.5, if they're at a 1.9. You have to look at the individual case and ask that person those 4 words that I bitch about conventional medicine not asking. You're functional, you are liable. Like this is part of your job. This is part of how you got that term functional, is you ask the person, how do you feel? And you take their symptoms and their answer to that question into account when you are dosing their thyroid medication. Get your eyes off of those labs. Get them off and ask the person how they actually feel. Because if you are dosing your patient's thyroid medication on that TSH value, you are going to end up screwing your patient. You are going to leave them in a hypo state. They will be crying out to you saying, please, please do something. This weight is not coming off. I am more fatigued than ever. I am counting the hairs that come out of my head. This doesn't make sense. And you bet your ass that they have done their own research. You bet your ass that they have listened to me. They have listened to Weston Childs. They have listened to Stop the Thyroid Madness. They've heard L. Russ. They've heard Karen Martell talk about Hashimoto's and hypothyroidism. All of these experts in this area of the thyroid, we're all saying the same thing. Look away from the TSH. Do not dose someone or diagnose someone based on TSH alone. Look at their free T3. Look at their free T4. Look at their reverse T3, making sure that that is optimal, and then ask them how they feel. Because if you don't, you will end up mistreating your patient the same way conventional medicine has done for years. And you will be no better. And you do not deserve the term functional. Take it out of your marketing material, take it off of your sign, and just stop practicing, or go back to the conventional space where you belong. Because I don't want you out there treating patients as a functional thyroid expert and dosing them off of TSH alone, dropping their T3 medication dose because TSH came back below 1. That's a problem. And patients are going to suffer, and it's going to come back on you, but patients are going to suffer in the meantime. We have to go back to basic biology. TSH is not a pituitary, or not a thyroid hormone, it is a pituitary hormone. If someone does not have a thyroid, in the case of, let's say they had Graves', let's say they had cancer, let's say that, you know, they had nodules, and doc said, hey, we have to radioactive iodine your thyroid. If there is no thyroid present whatsoever, take into account that there was a reason why that thyroid gland was removed. And it doesn't all have to point back to cancer. It can simply be a swinging from Graves' to Hashimoto's state. I've seen many patients that at the end, they had to get their thyroid removed because they were swinging. There was no control. They were truly going hyper because we weren't looking at just their TSH. We were looking at their Graves antibodies. We were looking at that free T3 and that free T4. And wow, that was super high. And they weren't even on thyroid medication. They were on methimazole to suppress thyroid function. Oh, they're still hyper. That does happen. And maybe that person had their thyroid gland removed because there was no controlling that Graves to Hashi swing, that hyper to hypo swing happening. Okay, then considering that, once you remove that person's thyroid and start replacing thyroid hormones properly, hopefully you don't put that patient on T4 only. That doesn't even make sense. That's a whole different podcast that I've done multiple times. There's zero chance of a patient being optimized who does not have a thyroid gland on T4 only. Because not only have you removed the gland that produced T3, you've also removed the main source of conversion from T4 to T3. When you took out that gland, the thyroid gland, or you radioactive iodined it. Zero chance of them being optimized. So let's say you actually have them on proper thyroid hormone replacement therapy, i.e. T4 and T3 of some kind, of some combination. There's many ways we can do this these days. We can change the ratio. We can use NDT. We can use slow release T3 if that person is sensitive to T3. There's so many different things we can do to get them to an optimized state. But in order to optimize them, you have to get your eyes off of the TSH. You have to get your eyes on that free T3, on the free T4. You test that reverse T3 every single time you pull their thyroid labs. You test, because you should know as a functional practitioner that if reverse T3 is high, you have them on too much T4. If free T3 is low, they need more T3, independent of what that TSH says, completely independent of that. So that is my bitch for the week. My what the hell are functional practitioners doing? Diagnosing and dosing patients based on TSH alone and actually freaking out if you're suppressed. That's a problem. It's a problem. And I'm hoping that some maybe listen to this and start changing up the way they're looking at that TSH. Get it out of your head. I know you learned it in med school. That's what they teach then. But now is your space, this functional space, to broaden your mind. And listen, if you're not a thyroid expert, I get it. I get being kind of pulled back into that realm. Just like I'm not an Epstein-Barr virus expert, and an EBV expert may look at your labs completely differently than I would. I'm looking down going, okay, well, you're not in an active state of EBV. So all is well, we'll support your immune system. Somebody else might look at that and go, okay, you're not active, but look at these numbers. They're sky high. We need to implement this treatment protocol and that treatment protocol. I don't claim to be an EBV expert. I'm functional. Thyroid, hormones, the nutrients surrounding them. Epstein-Barr virus definitely plays a role because we know it's a precursor to Hashimoto's, but that's not my area of expertise. And I'm not going to pretend that it is. So I'm not going to come in all high and mighty and start changing up your dose and think that I know what's best for you if that's not my area. And if you are functional and thyroid is your area and you're basing everything off that TSH, or you're even bringing it into your brain and panicking if you see a suppressed TSH, go back and bone up. Just sprinkle in some more education about the thyroid so you can properly treat your patients. And if you're a patient listening to this, it's all the same. I'm still complaining if you are with any practitioner that doses you based on TSH, that freaks out. You go, well, my doctor still tests free T3 and free T4 and reverse T3. But yeah, they panic when my TSH is suppressed. No, run, go, leave, run far away. Run far, far away from that person. Or at least have an educated sit-down conversation. But I like them, Amie. Okay, have a sit-down conversation with them saying, listen, can we talk about this? I know my TSH is suppressed, but everything that I learned about the thyroid, man, when you look at that basic biology, physiology, how the body works, hypothalamus, pituitary, thyroid, HPT. When we start looking at that, you know, I don't think that you should be changing my dose based on the TSH. Doc, you know, I'm seeing this free T3 over here and it's a 2.5. And by the way, you forgot to ask me, how do I feel? I'll tell you how I feel. I'm still experiencing symptoms, weight gain, haven't lost a freaking pound, and I'm still tired. Have that conversation then. If you are a patient listening to this and you are stuck with someone that is panicked over your suppressed TSH, you got to either go or you got to have an educated decision or educated conversation with this person. Your choice. You have two choices. Well, the third would be just to remain where you are and stay miserable. So you got to go, have an educated conversation, or stay miserable. Those are your three choices. Very blunt, very honest truth today. When things get in my craw and they start pissing me off, you're all going to hear about it because I'm going to bitch on here. Because that's the only way to get the message out and to stop. I don't want to use the term stop thyroid madness because that's already coined by Janie Bothorpe, who's amazing. But stop the freaking madness around the TSH. Stop the TSH madness. How about that? Let's coin that phrase. Stop the TSH madness. Don't even test it if it's going to screw with your head. If you're a practitioner, don't even test it. If you're a patient and you think that your practitioner is going to look at that, although they'll go, where's the TSH? I ordered it. It's not here. Take this information, be a patient advocate for yourself. Start knocking at the door of your functional practitioner that is using TSH alone to diagnose you.